Welcome everyone to today's radiology case discussion. So what we're going to do is we are going to discuss the anatomy of the wrist and try to simplify the wrist compartments and the related pathologies. This is a complex topic, so what we'll do is we'll try to go slowly and so that all of you understand. We'll not go in depth because we first need to understand the anatomy. Once we are clear with the anatomy, pathology is very easy, as in most MSK. So this is the typical anatomy, MRI anatomy for the wrist, and this can get really confusing. So when I see this anatomy, I get confused like this guy in this picture here. There are too many things to remember. It's a complex region. So what we'll try to do is we'll try to simplify each compartment, and we'll try to see if we can come up with useful tips for remembering what goes in each compartment. Once we are clear with that, the pathology is easy in most cases. Okay, so coming on to the first question that I have for you guys. So before we start discussion, so what anatomical landmark am I pointing to? So what is this anatomical landmark? You guys can type in your answer in the comment section, and for those who are watching it later, you can pause the video and type in the comment section. In the meanwhile, for those who are new, my name is Amar, Dr. Amar Udare. I'm a radiologist currently working at McMaster University Canada, and we do these live discussion over our YouTube channel. So moving on to the wrist anatomy. So this is the actual T1 section at the level of the distal radius and ulna. We'll go over each compartment and try to discuss the anatomy. So the wrist is divided into a extensor compartment and a flexor compartment. So the flexor compartment, so imagine when you flex your wrist, your hand is deviated towards your volar aspect, so I remember it that way, that the flexor tendons are in the volar aspect. Similarly, when you extend your wrist, your hand is deviated towards the dorsal aspect, so the dorsal compartment has extensor tendons. The extensor compartment is divided into six tendon compartments labeled as 1 to 6 here, and the flexor compartment consists of a large carpal tunnel and 3 structures which are outside the carpal tunnel, which include the flexicarpi ulnaris tendon, the flexicarpi radialis tendon somewhere here, and the palmaris longus, which is a tiny tendon. Palmaris longus is a vestigial muscle, so it has a tiny tendon here. So these are tendons which are outside the flexor, outside the carpal tunnel. This is a common question that is asked. What tendons are outside the carpal tunnel? So you can get an MCQ on this. Which of the following tendons are outside the carpal tunnel? And flexor carpi ulnaris, flexor carpi radialis, and palmaris longus are outside. So Guyon's canal. So what structure goes in the Guyon's canal? So Guyon's canal is located somewhere around here, not at this section, but a slightly distal section. It's bounded by the hook of the hamate and the hypothenar muscles. What structure goes in the Guyon's canal? Okay, so ulnar nerve, as Allah has rightly pointed out, ulnar nerve travels in the Guyon's canal. So imagine the ulnar nerve here going more distally. It'll go into the Guyon's canal, and it can be affected by fractures of the hook of hamate. So that's another important flexor compartment pathology. So today we are going to focus on the extensor compartment, and we'll try to remember pathologies for each compartment. So just to get you oriented, this is an axial section of the wrist on T1 weighted MRI. This is the radius, this is the ulna, and these are the 6 compartments: 1, 2, 3, 4, 5, and 6. So This, as you already rightly pointed out, this is the Lister's tubercle that divides the second and the third compartment. Another important point to remember. So the Lister's tubercle on the radius divides the second and the third compartment. Coming on to what stays in each compartment, it's difficult to remember because there are a lot of short forms for each. So we'll try to break these down and see if we can remember each of them. So the first, so as I said, this is the radial aspect, this is the ulnar aspect. So imagine the thumb to be here. So the thumb tendons would be in the first aspect, and imagine the little finger on this side. So the little finger tendons would be on this side, the thumb finger tendons would be on this side. So coming to the thumb tendons in the first compartment, the first compartment has, can anybody tell me what tendons are present in the first compartment? So the first compartment has extensor pollicis brevis and abductor pollicis longus tendons. The way I remember this is that so there is an extensor pollicis brevis and there is an extensor pollicis longus. So in the first compartment, the extensor pollicis tendon has to travel a shorter path because the thumb is right here. So the first compartment will have the brevis tendon, and because there is already a brevis here, there cannot be another brevis here. This is just a way of for me to remember. So just like there's an idiom in Hindi which says that two swords can't stay in one case. So remember that there can't be two brevis tendons together. So the second tendon here is abductor pollicis longus. So the two tendons in the first compartment are extensor pollicis brevis and abductor pollicis longus. Remember, the word pollicis is related to the finger, related to the thumb. So that way you can remember that the first compartment has tendons related to the thumb. So hopefully that is clear. Moving to the second compartment. So the second compartment has extensor carpi radialis longus and extensor carpi radialis brevis. So extensor carpi radialis longus and extensor carpi brevis. So those two tendons travel together. The third tendon compartment has extensor pollicis longus, and as we described, imagine that this tendon has to come here and go all the way to reach the thumb. So this is a long tendon, so that's why this is extensor pollicis longus and not extensor pollicis brevis. So I hope that the extensor pollicis tendons are clear. In the first compartment there will be extensor pollicis brevis because the tendon is short, while in the third compartment there will be extensor pollicis longus. Okay, is there any confusion, or this is clear now? So moving on to the third compartment, does anybody know what do we find in the third compartment? So the third compartment of the wrist, what resides in the third compartment of the wrist? So extensor pollicis longus, as we said, is in the third compartment, and in the fourth compartment we have extensor digitorum tendons and extensor indicis tendons. So this is a good chart to remember so you can take a screenshot here and then go over it again. The fourth compartment is the most crowded compartment, which has extensor digitorum tendons and the extensor indicis. The word indicis is related to the index finger. So remember that the indicis tendon goes along with the extensor digitorum tendons. Coming to the fifth compartment, as I had told you that the fifth compartment, imagine the little finger to be here. So the fifth compartment here has extensor digiti minimi. So the small finger is known as minimi. So extensor digiti minimi is in the fifth compartment, and the final compartment is the ulnar compartment. So that is the extensor carpi ulnaris tendon. Okay, so I hopefully this is slightly clear, slightly you have a slightly better understanding than before. I'll go over this once again because, as I said, this is a complex anatomy, and because of these short forms, it makes it difficult. So let's revise once again. So the first compartment has two tendons which go to the thumb. This is the radius, this is the ulna. The radial side will have the thumb. The ulnar aspect will have the little finger. So little finger tendons and ulnar tendons will be on this side, radial tendons and the tendons to the thumb would be on this side. So first compartment goes to the thumb. We have abductor pollicis longus and extensor pollicis brevis because it's a short tendon. Second compartment we have extensor carpi radialis longus and extensor carpi radialis brevis because we are on the radial side. The third compartment has extensor pollicis longus. It is a long tendon and goes to the thumb. That is why it is extensor pollicis longus and not brevis. The fourth compartment that is the most crowded compartment, which is the extensor digitorum and extensor indicis. After that, there is a small tendon for the small finger, that is the extensor digiti minimi, and finally along the ulnar aspect we have the extensor ulnaris, extensor carpi ulnaris. So moving on to the pathologies of each tendon, the most common clinically relevant syndrome is related to the first tendon, which is de Quervain's synovitis. For the second compartment, there are two interesting syndromes known as intersection syndromes. There is a proximal intersection syndrome and a distal intersection syndrome. Number 3 is the extensor pollicis longus tendon, and that can give rise to drummer's wrist. The fourth compartment is also known as fourth compartment syndrome or simply extensor tenosynovitis. A rare syndrome which is associated with the extensor digiti minimi tendon is Vaughan Jackson syndrome. This is very rare, but you can remember it for the purpose of MCQs. And finally, extensor carpi ulnaris tendon is related to snapping extensor carpi ulnaris. So if you have to remember tendons of the wrist, as long as you remember the anatomy, the pathology is very simple. What happens is that we have a lot of bony protuberances on the dorsal aspect of the wrist, and there is not much soft tissue. So imagine traveling in a crowded train. Say if you're traveling typically in India, if you're traveling if you're in Mumbai at Dadar, or if you're in Delhi at Rajiv Chowk, or anywhere like at a crowded railway station. If you have too many people cramped up into one space, there will be a lot of friction. You'll end up brushing people. You'll end up hitting against people. So imagine the extensor compartment as a crowded train compartment. What happens is that if there is excessive movement, or if there is a pathology, say a small fracture or chronic overuse, what happens is that these tendons either there is friction amongst themselves or against the bony protuberances, which gives rise to tenosynovitis. So the pathology in all these 6 compartment syndromes that I've talked about is same. It's tenosynovitis, which is tendon thickening and fluid in the tendon sheath. So on imaging per se, there is not much to talk about, but we'll still go over the common and the important points. But remember the wrist as a crowded train compartment, and all that friction going around. And so each compartment has its individual clinical presentation, and we'll go over each of them. So coming to de Quervain's tenosynovitis, so this is what we see is the first compartment. This is the first compartment, and so as we so just to revise, what tendon will be accompanying abductor pollicis longus in the first compartment? So de Quervain's tenosynovitis. In the meanwhile, you can type your answer in the comment section. So de Quervain's tenosynovitis will typically affect the first compartment, and there'll be chronic repetitive micro trauma in this region. So you'll get pain and swelling at the radial aspect of the wrist, and the clinical test for de Quervain's tenosynovitis is Finkelstein's test. So Rajat has rightly pointed out the extensor pollicis brevis tendon goes in the first compartment because it is a short tendon. Extensor pollicis longus is a long tendon because it's in the third compartment. So these two tendons can have a sheath in like a septum in between. Does anybody know what is the clinical importance for that from a management point of view? Normally they are in a single sheath, but sometimes they can have a septum in between. So the typical treatment for these is corticosteroid injection. So if the these tendons are in a separate sheath, we may have to give 2 injections instead of a single injection. So the clinical relevance is that we may need to give 2 injections. As I described previously, the pathology is thickening of the tendon. As you can see in this image, there is the tendon appears thickened and there is a lot of fluid and soft tissue edema around the tendon sheath. Coming on to intersection syndrome, remember the pathology, the analogy that I gave you about the crowded train. What happens is that a few of the tendons in the extensor compartment cross over each other, and because of this, whenever there is excessive movement at any of these intersections, they can give rise to intersection syndromes. As you see here, again, this is the wrist, this is the radial aspect, this is the ulnar aspect. You can see there is fluid around compartment 3 and there is fluid around compartment 2. So intersection syndromes affect the second compartment. It can either be a proximal intersection syndrome or a distal intersection syndrome. Proximal intersection syndrome is more common, and the reason that you have to remember the site of pain is because commonly in the wrist we will not cover this region. So if this is the wrist, the proximal intersection which occurs in compartment 1 and 2 muscles is, say, somewhere around 4 to 8 centimeter proximal to the wrist joint. So it is important to cover this region on your MRI to see the finding. Otherwise you will miss this condition. Distal intersection is less common and is seen in compartment 2 and 3 as seen in this case. So imagine this to be the extensor pollicis longus tendon. So this tendon is in compartment 3, but it has to reach the compartment 1. So it intersects with the second compartment and goes to the first compartment and supplies the and attaches to the thumb. So whenever there is friction between the second and the third compartment, that will give rise to distal intersection syndrome. This is less common as compared to proximal intersection, which will occur proximally around the wrist, where there is crossing of the compartment 1 and compartment 2 tendons. Again, the imaging findings would be tenosynovitis and soft tissue edema. So let's try for these. Let me try to play this video if possible. Okay, so unfortunately this video is not playing. We'll move on to the third compartment. So again, the third compartment consists of extensor pollicis longus, as we discussed, and tenosynovitis of the extensor pollicis longus can be seen due to I'll just switch on my pointer again. Okay, so the Lister's tubercle is here, and the extensor pollicis longus tendon travels very close to the Lister's tubercle, so that can give rise to chronic friction and a pathology known as drummer's wrist or drummer boy palsy. Another cause for this is a distal radial fractures. Remember, these tenosynovitis syndromes are common in rheumatoid arthritis and SLE. See extensor radiocarpi ulnaris and extensor pollicis longus, extensor digitorum. So these are commonly affected in these syndromes. So rheumatoid arthritis and SLE are associated with extensor and flexor tenosynovitis. Moving on to the next case. Also, as I said, as the name suggests, it's also seen in drummers because of chronic friction between the extensor pollicis longus and the Lister's tubercle. Extensor tenosynovitis is there's nothing specific about this compartment. Again, as you see here, this is a crowded compartment. So although there are a lot of tendons here, because they are in their own sheath, tenosynovitis is not very common here. Isolated extensor indicis tenosynovitis is known as extensor indicis proprius syndrome. Again, there is no specific clinical presentation for these. So as I said, extensor indicis proprius syndrome can be seen due to chronic overuse and muscular hypertrophy secondary to irritation and inflammation of the extensor indicis. Coming to extensor digiti minimi tenosynovitis, it can be affected like in any other tenosynovitis. A specific syndrome described in cases of rheumatoid arthritis is Vaughan Jackson syndrome, and there you see again tenosynovitis in the extensor tendon. Snapping ECU and ECU tenosynovitis. So the extensor carpi ulnaris tendon is prone to subluxation and tenosynovitis. It is the second most common tendon to be affected in tenosynovitis after compartment 1. So what happens is that this is common in rheumatoid arthritis and SLE again. There is thickening and thickening of the tendon with fluid around the tendon. An important thing to remember is that this tendon can normally have a small amount of high signal on water sensitive sequences. So it is important to remember that a small amount of signal may not be pathologic. There need to be other signs as well. So what is snapping ECU? So snapping ECU covers the spectrum of ECU tendonitis and instability. What happens is that with chronic tenosynovitis, the extensor carpi ulnaris tendon can get subluxated into on the ulnar aspect. So that's again common in rheumatoid conditions. So what we did today was we revised the extensor group anatomy, and we went over the pathology for each of these cases. Unfortunately, this video is not playing. But what you can do is you can head over to freitsrad.com. I'll leave a link to the website in the description section and the references for this talk. Before we leave, what we'll do is we'll quickly revise these tendon compartments, especially for those who joined in late or have joined in between the session. So the wrist is divided into extensor and flexor compartment. We have the extensor retinaculum on the external aspect. We have the flexor retinaculum on the flexor aspect. The extensor aspect has 6 compartments, while the flexor compartment has a carpal tunnel and structures outside the carpal tunnel. What are the structures outside the carpal tunnel? For those who have watched the lecture already, pause the video if you're watching it later or if you're watching it right away. So name 3 structures which are outside the flexor, the carpal tunnel. We'll move on to the discussion in the meanwhile. The first compartment has extensor pollicis brevis and extensor pollicis longus and can be affected in de Quervain's tenosynovitis. The second compartment has extensor carpi radialis longus and extensor carpi radialis brevis and can be associated with proximal and distal intersection syndrome. Proximal, as the name suggests, easy to remember, proximal will be associated with 1 and 2 and distal will be associated with 2 and 3. Proximal would be proximal to the wrist, higher up, and distal would be towards the thumb. Number 3 is extensor pollicis longus, which can be affected due to fractures of the Lister tubercle or chronic overuse at the distal tubercle. Compartment 4 has extensor digitorum tendons and extensor indicis. tenosynovitis in this region is rare. Extensor, now compartment number 5 has extensor digiti minimi. Remember that this is the little finger side, this is the thumb side, this is the ulnar side, this is the radial side. So ulnar tendons would be this side and radial tendons would be this side. So we have extensor digiti minimi in 5th compartment, and finally in the 6th compartment we'll have flexor carpi ulnaris tendon, extensor carpi ulnaris tendon, which is prone to snapping syndrome, which is tenosynovitis and ulnar subluxation. So hopefully I have simplified the anatomy of the wrist. You can go over the discussion. I've tried to cover it multiple times, but you can go over the video repeatedly and try to teach it to a colleague or a junior of yours so that you'll remember. I often get confused and I had trouble remembering it, so I thought the easiest way would be to teach you guys. So as always, if you have any questions, you can let me know in the comment section. And if you like the video, make sure you give it a thumbs up. And if you didn't like what we discussed today, feel free to give a thumbs down. And if you have, and just mention in the comments how we can improve all our videos. And if you're new here, make sure you hit the subscribe button. And you can let me know in the comments what topic would you want me to cover the next time. So I'm trying to simplify complex topics. The wrist anatomy I thought was a common topic which I often confused, so I thought I will cover it in today's talk. Again, if you like the video, make sure you hit the like button. That helps with the YouTube algorithm and helps the stream to reach more people.